Hello, thank you very much for the kind introduction and also for the invitation to be here and share the work that we have been doing in the last almost 2 decades in the field of osteoarthritis biomarkers. I'm truly sorry I'm not be able to be present there and meet you in person. I wish you a very successful meeting, and I will show you the latest testing that we have been doing in the lab regarding osteoarthritis biomarkers. First of all, this is the outline of my talk. I would show you a little bit basic concepts about biomarkers, then how they can be used to enable precision or intelligent medicine strategies in osteoarthritis. And finally, in a second part of my talk, I will show you some applications of how we can introduce these molecular biomarkers in predictive models useful to improve the management of osteoarthritis. So starting with the most basic concepts of biomarkers, there are characteristics that can be objectively measured and evaluated as indicators of a situation, even either health or disease or response to treatment or an intervention. So these characteristics, of course, can be different from different origins. They can be molecular, histologic, radiographic, or physiologic. I will focus my talk more on molecular biomarkers, but among all these different types of biomarkers, we can define two different groups. Clinical biomarkers that are clinical features and imaging that are MRI, for example, or radiographics, etc., are so-called dry biomarkers, where molecular biomarkers can also be defined as wet biomarkers. But I like another classification most, and this is the one that describes the different biomarkers between descriptive biomarkers, which are those that reflect indirectly the state of the disease, and therefore are describing phenotypes that are can be observable. And so this kind of descriptive biomarkers can be used for the diagnosis of symptomatic disease or the evaluation of disease activity, but are not really involved in the pathogenic mechanisms that are occurring in the disease. So an example of this could be, for example, acute phase reactants that can be detected as a consequence of the inflammatory response that is occurring in some inflammatory diseases, but that are not directly involved in the pathogenesis of the disease. The other type of biomarkers in this case are defined as mechanistic biomarkers, and in this case they are directly related to the pathogenesis of osteoarthritis, and therefore they can be also used for the diagnosis of a symptomatic disease and employed in prognosis or prediction studies, because they do not define phenotypes but endotypes. And defining endotypes, which are, I'm going now to explain this to you, it's very important in the case of osteoarthritis, because osteoarthritis is a very complex pathology. You all know about this. And in osteoarthritis, in the last recent years, we have defined different OA phenotypes that can explain the different characteristics that patients are suffering. So some patients have more a mechanical phenotype due to intensive, for example, intensive sports training, or other patients have display a more aging phenotype related with aging, or metabolic or inflammatory. These four phenotypes, of course they can be more, but to simplify the situation, these four phenotypes that are observable entail endotypes that are molecular mechanisms that underlie these clinical features. So in the case, for example, of the mechanical phenotype, we can see processes of intensive matrix degradation or collagen loss. In the case of, for example, the metabolic phenotype, we see an altered metabolism or mitochondrial dysfunction. There is another phenotype of osteoarthritis that is more inflammatory, in which we can see more abundance of inflammatory mediators. And these molecular mechanisms are very important because they can also be useful to drive also the therapeutic strategy to be applied to the patient. So these are also called the osteoarthritis theratypes, that are distinct therapeutic subtypes. So in the case, for example, of a patient showing a more metabolic phenotype, maybe he can be treated with more anti-diabetic agents or with diet, whereas if his or her phenotype is more inflammatory, he can be better treated with anti-inflammatory drugs. So this differentiation between phenotypes and endotypes is very important to enable precision medicine, in which we moved using molecular biomarkers to prevent, diagnose, and treat the patients adapted to the molecular uniqueness of each patient and each disease. And this is the definition of precision medicine, in which the clinician does not work based on recognition of patterns, but on decisions based on knowledge. And this knowledge is made because we have better defined better the disease, especially at the molecular level, and this also requires, and it's very useful for this to attain this objective, to introduce the omics technologies more deeply into the procedures. And why is this important? Because the omics technologies, genomics, transcriptomics, proteomics, or metabolomics, these omics technologies enable the large-scale characterization of molecular profiles in the patients that can contribute, while imaging markers and clinical markers contribute to define the phenotype of osteoarthritis, the molecular markers can also be useful to define these endotypes. And this is also very interesting, because in the case of osteoarthritis, you all know that osteoarthritis is a very long a disease that has a very long evolution time, in which we have some early stages in which neither the patient has symptoms and we don't see any radiographic features. Then we move to early disease when some subtle signs can be detected with magnetic resonance, and once the disease is consolidated, when we have symptoms and radiographic and MRI signals, it's when the disease is already established and we are not able to stop the disease, and the patient usually ends with the advancement of the disease. The patient usually ends with a total joint replacement. So it's very important to know that the molecular biomarkers can already be altered here. So these subtle molecular changes can be detected here. In this case, we could make an intervention or with the patient in order to try to make the progression of the disease, slow the progression of the disease. So for several years, a lot of molecular biomarkers have been studied in OA. This is a review that was released last year, and we have here, shows you here the different types of biomarkers. These can be metabolites, and some of them have been analyzed in osteoarthritis, microRNAs, also cytokine mediators, inflammatory mediators, and proteins. So since I've been working for most of my research in proteomics, I will focus the rest of my talk more in protein biomarkers, which I find are the most related with the function and the processes that are taking place in the disease. And these protein biomarkers have also been for a long time studied in osteoarthritis. This is also a review back from 2014, but here you can see the different functions that the protein biomarkers are related with in OA. Some of them are related with proteases, synovial inflammation, the production of extracellular matrix, and the destruction of this extracellular matrix mainly in cartilage, but also in subchondral bone. And there have been studied also other proteins related with signaling and inflammation. So many proteins have been analyzed, but few of them have progressed into clinical trials and have shown really biomarker value. Many of these proteins are really not proteins itself, but fragments of proteins with the so-called protein neoepitopes that can be released from extracellular matrix from cartilage or synovium, for example. The most studied traditional biomarkers in osteoarthritis have been fragments from type 2 collagen that are cleavaged by proteases, these different proteases, and are released and can be detected. and these are and other that have been not so widely studied are fragments from aggregate. But this is an example of traditional biomarkers that have been explored in osteoarthritis. These biomarkers, the interesting part here is that these biomarkers can be introduced in algorithms and in predictive models to achieve this movement to precision medicine strategies in osteoarthritis. And these biomarkers can be used at different stages of the evolution of the disease. They can be used at the preclinical phases to predict if the patient is going to develop osteoarthritis or not. That is to predict the incidence of osteoarthritis, or in more advanced stages, from early OA until moderate or advanced OA, they can be used to predict progression. They can be used at the end in really advanced stages of OA to predict if the patient is going to need total joint replacement, or even to predict if the patient is going to respond to an intervention or not. So these are very different types of biomarkers. And now I'm gonna move to the part of where I will describe some of the application of these biomarkers in models, starting with the prediction of total joint replacement. And I show you here this work from an Icelandic group that was published in 2021. And in this case, these people made a proteomic analysis to scan many Icelandic cohort of almost 40,000 individuals, and they measured using this a tool that is the SomaScan platform that is able to measure on more than 4,700 proteins in plasma, and they identified this protein that is the cartilage acidic protein 1, that is associated with the progression to joint replacement in both in knee and in hip osteoarthritis. This was a pioneer study with a very large population, and was validated in a second study that was published last year from the same group, using a different proteomic platform, in this case the Olink platform, but that is homologous, so it's really similar to the SomaScan one, but they used a different proteomic strategy and also a different cohort, in this case the UK Biobank, with more than 50,000 individuals. And the cartilage acidic protein 1, they validate and they confirm that increased levels of this protein 1 in plasma are associated with a higher risk to joint replacement. So this is an example of how proteomics and the study of protein biomarkers can be useful in prediction studies for joint replacement in osteoarthritis. Remarkably, another research group, in this case in Rotterdam, found more or less the same results using the Rotterdam study cohort and more focused Olink platform strategy. They found also this cartilage acidic protein 1 as a predictor for molecular biomarker for OA severity and progression. And this is an example of how these biomarker-based predictive models can be useful, not only based on this cartilage acidic protein 1, but also using other molecular markers that are related with joint destruction, can be used to predict the risk of the patients to undergo total joint replacement. Another application of molecular biomarkers in predictive models is the one devoted to the predict progression. Last year, the Virginia Krause group in the Duke University in the US published this work, in which using a different strategy as the ones that I showed you before. In this case, this was a proteomic strategy based on mass spectrometry analysis. They analyzed two different cohorts, the FNIH and the BMF cohort, to try to find biomarkers that are associated either with osteoarthritis structural or brain progression that can be clinically relevant, and using also an analysis based on machine learning, in this case ElasticNet, they found different panels of markers that can be associated with this progression, and finally developed a model that is based on of 15 peptides that are these listed here that are useful to build a model to predict this progression. In this area, our group has participated in a multicentric European project called the Approach cohort that combine academic and small and medium enterprises and also large pharmaceutical companies. Also, that was also focused in trying to identify those individuals that are more likely to progress quickly in time, either in pain or progression. That could be, in principle, that could be ideal to be recruited into clinical trials for osteoarthritis. And this project built a cohort that is called the Approach cohort that was followed for 2 years. And after this follow-up, 3 different phenotypes were defined: those patients that had progressed in pain during these 2 years, those that progressed in structure measured by X-ray and MRI, and those that did not progress in any of these phenotypes. And our group was led the proteomic analysis of this cohort. So we analyzed by proteomics the samples from these patients at baseline and at the end of the study at 24 months of follow-up, trying to find predictors of the progression in pain or structure, or markers of this progression, or comparing the 2 time points, trying to analyze the dynamics of proteins during these progression stages. So this is a manuscript that we are now finalizing and will try to send in the following months. Another application of these molecular biomarkers can be to try to predict the response of the patient to an intervention, and also that can be a drug or can be surgery, etc. To this end, I show you here a work that we performed that we published in 2019, in which we employ this cohort that is called the MOVES, that comes from this clinical trial that is described here in this paper. And it was a clinical trial that wanted to aim to compare the effects of a combination of chondroitin sulfate and glucosamine for painful knee osteoarthritis with celecoxib. And so we used samples from this clinical trial at baseline and performed a proteomic analysis on different stages from the discovery to the qualification phase. And finally, we found 2 proteins that were included in predictive models together with clinical variables, trying to predict the response of that these biomarkers could predict the response of the patient to the treatment with either of these 2 different treatments. So the rationale of this study was that potentially the patient can come to the clinic, these proteins can be measured in his or her serum, and then the serum levels can guide the clinician to give the patient either celecoxib or the slow symptomatic action drugs, Cisadoa, the chondroitin sulfate or the glucosamine sulfate. So this with this work, we developed a model based on these 2 proteins to predict the therapeutic response. And this work was difficult to validate because the clinical trials, there are no clinical trials similar to the MOVES one, and so this limited the application of the work. But finally, I moved to the last part of application of the biomarker-based predictive modeling that I'm showing you, that is the one focused in predicting OA incidence, that is moving to the most early stages of the disease, which is something that is currently one of the most interesting focus of research in OA, because predicting OA and its incidence and trying to diagnose it as early as possible is very important to enable early management of the patients, correct modifiable risk factors such as weight or diet, etc., and also restore joint homeostasis. So in this field, some years ago, we had discovered a panel of peptides by proteomics that were useful to classify OA versus healthy individuals. So in this case, what we did, we developed a method to measure the proteins containing these 11 circulating peptides, that are these 4 proteins, and we developed an immunoassay to in a multiple way quantify these 4 proteins in serum from patients. And we took the OAI cohort, that is a cohort, an American cohort that's focused on knee osteoarthritis, and we measured these 4 proteins at baseline in a cohort of patients that had no any radiographic sign of the disease in either of the 2 knees. They had a Kellgren-Lawrence grade of 0 at baseline, and we measured these proteins, and we found how biomarkers, some of these 4 protein biomarkers can be useful to predict the incidence of the disease in the next following 8 years. As you can see here in these rock curves, the clinical model that included traditional risk factors of osteoarthritis such as age, sex, BMI, and the WOMAC pain score can classify those individuals that are at risk of incidence of knee osteoarthritis with a 70% of accuracy. But when we introduced 2 of the biomarkers that we were studying, we increased this accuracy up to an 82%. And this difference, this improvement, is statistically significant. So this demonstrated the usefulness of including molecular biomarkers into the clinical models to improve the sensitivity and the specificity of the predictions that we are making. In this same work, we validated these findings in another cohort. In this case, it was the PROCOAC cohort, that it's a cohort that was built within our hospital. And as you can see here, although the accuracy of the method was a little bit lower in the validation cohort than in the discovery one, the differences between the 2 cohorts were not statistically significant. Thus, we could validate the model, and we also developed a nomogram, which is like a kind of calculator, including these variables, the clinical variables, and also the measurement of the levels of these 2 protein biomarkers, so that this can be applied in clinical practice in the way that the patient comes to the clinic, depending on the values that he has in these different variables, he gets a number of points, and these points are translated into a quantitative risk of incidence of having osteoarthritis in the next 8 years. This work was published in January of this year, 2024, in Annals of the Rheumatic Diseases, and last month the group of Virginia Krause published in Science Advances also a study of the application of biomarkers, molecular biomarkers, to predict incidence of knee osteoarthritis in this work. And this study was commented in the NIH Research Matters because it highlights, such as well as our previous study, how the measurement of blood biomarkers, markers in blood of proteins that are related, can be related with osteoarthritis pathogenesis, may be useful to predict the incidence, and also to monitor how the pathophysiology of osteoarthritis is evolving. So because these molecular biomarkers are dynamic, so that we can monitor the progression of the disease using this analysis of levels in blood. So finally, just to summarize all this talk, I would like you to take home these brief messages. The first one is that the implementation of precision medicine in osteoarthritis, of course, relies on the improvement of its characterization at the molecular level, because we need to know better how molecular pathways are being modified to try to characterize better this disease. Also, that emerging molecular biomarkers are really a key to advance into these precision medicine strategies, and omics technologies. I have highlighted more proteomics because it is the omic I work in, but other omics are an ideal source for the identification of molecular markers, and indeed they are increasingly being applied in the procedures, and we are getting lots and lots, a huge amount of data coming from these omics technologies, and thanks to the advancement in machine learning and in intelligent medicine technologies that are useful and are able to manage this huge amount of data, we are having lots of results. So this is something that is being increasingly widely and more widely used. And finally, and this is the final conclusion of my talk, that the combination of these protein molecular biomarkers with clinical variables in predictive models has a great value to enable precision medicine and also to improve patient management. We are going to be able to give more tailored treatments, more tailored procedures to intervene earlier in time and trying to prevent the progression of the disease, and this will benefit the patient. And that's it. So I finally would like to acknowledge my group. This is my group in La Coruña, the Rheumatology Research Group led by Francisco Blanco, and this is these are the people that work with me in the specifically in the proteomics unit of this group, and I would like to thank you all for your kind attention. Thank you very much.